What happens to women's cardiovascular risk at menopause? Hello and welcome to the channel. I often get perimenopausal women coming to see me in panic because of a sudden weight gain, which prompts me, more often than not, to look for, ironically, pregnancy. And then there are the hot flushes and dizzy spells. What else happens to a woman's cardiovascular risk around or after menopause? Menopause is a significant physiological transition in a woman's life, typically occurring between the ages of 45 and 55, characterized by the cessation of menstruation and a significant decline in estrogen levels. While often discussed in the context of reproductive health, menopause has far-reaching effects on many physiological systems, particularly the cardiovascular system. The shift in hormonal balance during menopause significantly alters a woman's cardiovascular risk profile, increasing the likelihood of heart disease, stroke, and other vascular conditions. The role of estrogen in cardiovascular health. Estrogen is a key hormone that plays a protective role in cardiovascular health in premenopausal women. It has several direct and indirect effects on the cardiovascular system, including improving endothelial function, meaning the inner lining of blood vessels, function, enhancing vasodilation, dilation of a blood vessel, through increased nitric oxide production, reducing inflammation, and influencing lipid or cholesterol metabolism. Estrogen also helps maintain the balance between HDL, high-density lipoprotein, and LDL, low-density lipoprotein cholesterol, which is crucial for preventing atherosclerosis, a major contributor to cardiovascular disease, CVD. In premenopausal women, estrogen contributes to a lower risk of cardiovascular disease compared to men of the same age. This protection diminishes with the onset of menopause as estrogen levels decline. The drop in estrogen levels leads to several physiological changes that collectively increase the risk of cardiovascular disease. One of the most pronounced changes associated with menopause is the change in lipid metabolism. Studies have consistently shown that postmenopausal women experience adverse changes in their lipid profiles, including an increase in LDL cholesterol and triglycerides and a decrease in HDL cholesterol, LDL being the bad guy and HDL being the good guy in the story. These changes significantly contribute to the development of atherosclerosis. LDL cholesterol is the bad cholesterol because high levels can lead to the buildup of fatty deposits in the arteries in cardiovascular disease, atherosclerosis. This buildup can restrict blood flow, increase blood pressure, and heighten the risk of heart attack or stroke. Postmenopausal women often experience an increase in LDL cholesterol, largely due to the reduced estrogen levels that no longer regulate lipid metabolism as effectively as before. HDL cholesterol, on the other hand, is known as a good cholesterol because it helps remove cholesterol from the bloodstream, transporting it to the liver for excretion. Estrogen enhances the production and function of HDL, but after menopause, HDL levels tend to decline, further tipping the balance towards atherosclerosis. Triglycerides are another important factor in cardiovascular disease. Elevated triglyceride levels are associated with an increased risk of heart disease, particularly when combined with low HDL and high LDL levels. Postmenopausal women frequently show a higher triglyceride level, which is another way in which menopause can contribute to cardiovascular risk. Menopause is often accompanied by changes in body composition, with an increase in visceral fat being one of the most concerning changes. Visceral fat, or fat that accumulates around internal organs, is particularly dangerous as it is associated with insulin resistance, inflammation, and an increased risk of cardiovascular disease. So often people talk about this apple shape, meaning that the middle of the body becomes larger and rounder, filled with visceral fat that is sitting around the liver, the pancreas, in the abdominal area, even around the heart. This kind of fat is bad for us, and this is the kind of fat that we should be eliminating when we engage in weight loss strategies. It's not about just losing weight, it's about losing this particular type of fat, the visceral fat. Insulin resistance, a condition in which cells in the body become less responsive to insulin, is a major risk factor for type 2 diabetes, which in turn is significant in that it's an independent risk factor for cardiovascular disease, heart attacks, strokes, and peripheral vascular disease. Postmenopausal women are at increased risk of developing insulin resistance due to the hormonal changes and associated weight gain that often occur during this period. The combination of increased visceral fat, insulin resistance, and higher sugar levels increases a metabolic environment, or creates rather a metabolic environment that is highly conducive to cardiovascular disease. Weight gain is a common complaint amongst postmenopausal women, and it often involves an increase in central or abdominal fat, as I have previously mentioned. This particular type of fat is closely linked to a metabolic syndrome, a cluster of syndromes or conditions including high blood pressure, high blood sugar, excess body fat around the waist, and abdominal cholesterol levels, all of which together and separately increase the risk of heart disease, stroke, and diabetes. Blood pressure tends to rise after menopause, contributing to the increased cardiovascular risk profile of postmenopausal women. Several factors contribute to this rise, including changes in the regulation of vascular tone, the underlying muscular elasticity of the blood vessel involved, increased arterial stiffness, and a reduction in the vasodilatory effects of estrogen. So a reduction in how much the blood vessel can open up, which is usually something that was under the control of estrogen, but with falling estrogen levels, it's no longer possible. The loss of estrogen leads to changes in the structure and function of blood vessels. Arteries become stiffer, and the endothelium, the inner lining of the blood vessel, becomes less responsive to circulating hormones that either widen it or constrict it. It becomes less elastic. Endothelial dysfunction is a critical factor in the development of atherosclerosis and hypertension, as it impairs the ability of the blood vessels to dilate in response to increased blood flow. Estrogen promotes the production of nitric oxide, a key molecule that helps blood vessels relax to maintain a healthy, flexible state. In postmenopausal women, the reduction in estrogen results in less nitric oxide production, contributing to endothelial dysfunction and increasing the risk of hypertension and atherosclerosis. Menopause is associated with an increase in systemic inflammation and oxidative stress, both of which are key drivers of cardiovascular disease. Chronic low-grade inflammation is a common feature of aging, but it's particularly pronounced in postmenopausal women due to the decline in estrogen, which has anti-inflammatory properties. The question of aging and cancer crops up often in medical studies, clinical trials, because of the link between many cancers and simple aging. The risk of cancer increases year on year within us all. It depends what type of cancer, of course, but in general, the inflammatory processes that lead to autoimmunity, for example, and cancer both increase significantly. Studies have shown that postmenopausal women have higher levels of inflammatory markers such as C-reactive protein, CRP, interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-alpha. These markers are associated with an increased risk of atherosclerosis and cardiovascular disease. The rise in inflammation is thought to be related to changes in fat distribution, with visceral fat being particularly pro-inflammatory, which is why it is always advisable in any weight loss strategy to build muscle as a way of replacing the lost fat. There are technical reasons for this, which I can't go into one day if the demand is there. Talking about interleukin-6 reminds me of yet another interaction between medicine and locations. I'll explain. The interleukins are a family of immunological hormones, if you like, transmitters that talk to each other within the immune system. Let's call it the body's FBI agents. Now, how did we arrive at this name? Interestingly, Switzerland plays a part. Did you know that during the 1979 Second International Lymphokine Workshop, a workshop by scientists to discuss the cells within the immune system, it was decided that to describe the interchange between these various enzymes and hormones and transmitters, that they be called interleukins because they are all part of the leukocyte system, so the white blood cell system. And somebody had the idea to call it interleukin because it sounds like Interlaken, which is of course a town in Switzerland between two lakes. Bonus points for naming the lakes. Okay, I'll tell you. The lakes are Brienz and Thun, of course. Thunersee and Brienzersee. So we have immune cells, immune hormones, immune agents in the body getting their name because it sounds like a town in Switzerland. And this is the theme of this video, where I talk about how many diseases and bugs get their name, basically linked to a location, whether it's for good or for bad. So, after depressing everyone with the ills of the menopause, is there a solution in sight? Yes, of course, there are several. The main one, of course, being what we call hormone replacement therapy. Hormone replacement therapy, or HRT, has been widely used to alleviate the symptoms of the menopause, such as the hot flushes, the night sweats, vaginal dryness. However, the effects of HRT on cardiovascular health have also been the subject of considerable debate and research over the past several decades. Is HRT the answer? Well, there are pros and cons. I shall start with a very prominent con, just because it's a rather important con, and that is thrombotic risk. What do I mean? By thrombotic risk, I mean blood clots in the veins of the legs, sometimes of the arms, and also within the pulmonary artery system. This risk is increased in hormone replacement therapy and also with the pill, the oral contraceptive, when it includes estrogen. So either the combined oral contraceptive with a reduced risk with the progesterone only pill. Here is a little anecdote to further explain my encounter with thrombotic disease due to hormone replacement, or its equivalent for the younger ladies, the pill. I will never forget one rather unpleasant assignment I had as a junior doctor, where it was my turn to turn up at the hospital morgue down in the basement of the hospital to witness an autopsy of one of our patients who had sadly passed away overnight. Hospital teams operate as little firms or enterprises, if you will, made up of doctors of different hierarchy based on experience. Unsurprisingly, the lowest ranked member of each firm gets to do the most undesirable tasks for the firm. That's life. The expression, taking one for the team, is how best I can describe this scenario. I took one for the team on many occasions. In all seriousness, I was selected, in inverted commas, to go witness this particular autopsy, which was one of the most harrowing things I have ever witnessed as a doctor. And I have seen some pretty harrowing things in my career so far. The patient was a bubbly young woman who had been admitted overnight with breathlessness and chest pains and a swollen left leg. She'd been on the pill for a few months. We quickly and correctly diagnosed her problem and started treatment. Basically, we started to thin her blood. But somehow, her pulmonary embolus, blood clot to the lung, had already gotten to an advanced stage. And she arrested on us in the early hours of the morning, despite being on anticoagulant medication. Having been up all night with her and other patients, and having spent the morning meeting with her parents, by the way, she was an only child, and her friends, I was chosen to go witness her autopsy before departing to bed and coming again back to work the next night. In a haze, I watched as this beautiful and full of life woman was cut open and her body dissected before my eyes in the most gruesome and tragic twilight zone in my life, whilst the words of her rather religious mother were ringing in my ears the whole time. All this happened just to prevent her giving me a grandchild? The saddest thing of all was that this young lady was due to get married in a few months' time. The risk of blood clot with the pill and HRT are similarly elevated in arteries, like the coronary arteries, the arteries around the heart. The pill and HRT make blood sticky, or at least increases the stickiness of blood. This is why oral contraceptives are denied to women who have a personal or family history of blood clots. It can be lethal in such cases. There have been early observational studies which suggested that HRT might have a protective effect on cardiovascular health, as women who used HRT seem to have a lower risk of heart disease. We have learned earlier on in this video that the falling estrogen levels cause a hotbed of increased cardiovascular risk because estrogen is actually protective. So logically, you would expect that to rebuild the estrogen profile in a woman's body should reduce her cardiovascular risk. And these early studies showed that this was true. However, these studies were later found to be biased because the women who chose to use HRT in those studies were often healthier to begin with. The Women's Health Initiative, WHI, a large randomized controlled trial conducted in the early 2000s, changed the prevailing view on HRT and cardiovascular risk. The WHI found that HRT, particularly when initiated in older women, so 10 years or more after menopause, was associated with an increased risk of heart disease, stroke, and blood clots. These findings led to a significant decline in the use of HRT for cardiovascular protection in postmenopausal women. So, the conclusion, as it appears to me, is HRT may provide cardiovascular benefits when started early in menopause, but it may also increase the risk of heart disease and other conditions in older women or those with certain risk factors. The jury is out on that one, it would seem. Cardiologists, in collaboration with gynecologists, of course, are advised to take a stratified approach when treating women with HRT. Treatment is low risk in women with recent menopause, normal weight, and normal blood pressure, who are physically active and have a 10-year atherosclerotic cardiovascular disease risk of less than 5%, as well as a low risk for, by the way, breast cancer. HRT is also known for its slightly increased risk of breast cancer in postmenopausal women. Treatment is intermediate risk in women who have one or more of several risk factors: diabetes, smoking, hypertension, obesity, sedentary lifestyle or limited mobility, autoimmune disease, hyperlipidemia, high cholesterol, metabolic syndrome, and those who have a 10-year atherosclerotic cardiovascular risk from 5 to 10%, or who are at high risk for breast cancer. And these are the women with a family history of first-degree relative breast cancer, so a mother or a sister who have breast cancer. Treatment is high risk in women who have congenital heart disease, atherosclerotic cardiovascular risk, or coronary peripheral artery disease, blood clots or pulmonary embolism, stroke or heart attacks, or breast cancer risk, or who have a 10-year risk of atherosclerotic coronary vascular disease or cardiovascular disease risk of more than 10%. It is indeed a tricky balance. Add in the risk of womb and breast cancer, and HRT becomes a very tricky subject. How then to navigate the horrendous symptoms of menopause and to mitigate the increasing risk of cardiovascular disease at the same time in the very population who are in a risk-evolving situation? Well, there is a natural approach for a start. It's a long road, but well worth the journey. Healthy diet. We all know that a healthy diet can grossly mitigate the risk of heart attacks, heart disease in general. Women, postmenopausal women in particular, should focus on consuming a diet rich in fruits, vegetables, whole grains, lean proteins, and healthy fats, such as those found in olive oil and fish, limiting saturated fats, trans fats, and refined sugars, as well as processed carbohydrates, can help control cholesterol levels and prevent atherosclerotic disease of the heart, and of course blood vessels. Regular physical exercise is critical for maintaining cardiovascular health. We all know this. Aim for at least a couple of hours of moderate intensity aerobic exercise per week, such as brisk walking or running or jogging or cycling. Exercise, of course, controls weight, reduces blood pressure, improves cholesterol levels, and lowers the risk of heart attacks. In many ways, exercise combined with diet is almost as effective as medication, at least as a prevention strategy against cardiovascular disease. Weight management, smoking cessation, managing stress, regular health screenings are all important strategies that one can deploy in mitigating the horrendous complications of menopause. Other than these natural and self-enforced strategies, there are a middle ground between these natural ways of reducing the risk of complications of menopause and hardcore medication, hormone replacement therapy, and that is plant-based, herbal or homeopathic remedies for menopause symptom relief and also to reduce cardiovascular risk in women, particularly early on in menopause. These include medicines based on the plant chimichifuga or black cohosh, a treatment which is rather popular in Switzerland, so much so that the insurance will happily pay for it. I'm sure there are others. Do let me know in the comment section if you have special intelligence on this matter. Don't worry, you can give us a coded message and we won't let in on our sources. Although I didn't focus on other effects of menopause, such as osteoporosis risk, do you have any information about this tool that you would like to share with us? It's an open forum here. Share your thoughts, ideas, strategies, and wisdom with us. And of course, if you have a question you would like me to answer, feel free, by all means, Askadoc.